Sir, we can start, sir. Please.
Yeah, thank you.
Thank you.
So good evening all, and welcome you for this ninth issue of OcuHealthscapes, which is the monthly update on environmental and occupational health issues, local, regional, and global. For that, we have our most eminent speaker, Dr. Rajiv Kumar Jain, who is a member, managing committee of Epidemiology and Occupational Health, and also ICO, and is a vice president of Association of Environmental Health and Occupational Health, Delhi. He is a senior consultant, Indian Railways, New Delhi. He has got rich experience of 40 years in health and occupational and hospital administration. He has got numerous awards, to name few: Fellow Award of Indian Public Health Association, Fellow Award of Association of Environment and Occupational Health, Delhi. He has published and presented more than 145 scientific papers in national, international conferences, journals, and books. He has got numerous scholarship by eminent organizations in the world, including WHO, and there is a big list of achievements, and he is a role model for any occupational physician in India. And without taking much time, before I hand over, please mute your microphones, and we can have questions at the end of the session. Dr. Rajesh, sir, the floor is yours.
Thank you, Dr. Guru Prasad. We have actually collected here today to refresh our knowledge about occupational and environmental health. Once again, as we always do on last Friday, 6:30 p.m. every month. And also, I would like to share with all the attendees that the video is, all the past videos are also available on the Enoch DigiConnect webinar platform on YouTube. If you want to refresh your knowledge, all the past videos of OcuHealthscapes are available for you to watch anytime that you wish to see them again, and all the slides, because it is a continuous process, and knowledge never ends. It never begins at any point of time. It's a continuous process. That's why we do research. So without taking more time, I go and start my presentation for today for occupational and environmental health issues and update, which are regional, local, and global in nature. And at the end of the session, we wish to be updated on the happenings in the world of occupational and environmental health during the past 1 month, whether it's local, regional, or global in nature. So let's see what is in store. So here we go. Next slide, please. Now, the most important event during the last 1 month was the Inter-Parliamentary Panel for Climate Control, IPCC, the report that came out. And it gave a policy directive. It actually laid down the roadmap for the world leaders and the citizens of the world, whether they are located in north of the world or south of the world, or in locations which are not inhabited, or in locations which are heavily inhabited. And one sentence which stands out is, it is unequivocal that human influence has warmed the atmosphere, oceans, and land. Extreme sea level events may become annual, causing floods in coastal areas. Rain will become erratic intense rain will trigger flooding, and inadequate rain will cause droughts in others. Glaciers, rapid loss of snow cover, glaciers and ice sheets shall be in store. Oceans, frequent marine heat waves, acidification, and low oxygen levels are likely. Let's see further. Next slide, please. The 5 futures. What are the 5 futures? The IPCC report uses 5 possible scenarios for the future, which predict how the climate crisis will unfold depending on the socio-economic choices of nations. The leaders of the world, the citizens of the world will have to make choices. And we must understand what are these scenarios. They are the result of calculations which are based on how quickly humans curb greenhouse gas emission and are meant to explore socio-economic changes in areas such as population, urban density, education, land use, and wealth. For example, a rise in population is assumed to lead to higher demand for fossil fuels and water. Each scenario is labeled to identify the emission level and the shared socio-economic pathway, or SSP, in these calculations. And what you see in the graph is SSP 8.1, 7.0, 4.2, 4.5, 2.6, and 1.9. And the vertical line on the left is today, that is 2020 end. And at SSP 5 8.1, which is very high emission, this is a future to avoid at all costs. Current carbon dioxide emissions levels roughly double by 2050. The global economy grows quickly, but growth is fueled by exploiting fossil fuels and energy intensive lifestyles. By 2100, the average temperature would be scorchingly 4.4 degrees centigrade higher. At SSP 3 7.0, it will be high on this path. Emissions and temperatures rise steadily, and emissions roughly double from current levels by 2100. Countries become more competitive with another, shifting towards national security and ensuring their own food supplies. By the end of the century, average temperature have risen by 3.6 degrees centigrade. At orange, SSP 2 4.5, which is intermediate, this is a middle of the road scenario. Emissions have hovered around current levels before starting to fall mid-century, but do not reach net zero by 2100. Socioeconomic factors follow historic trends with no notable shifts. Move to sustainability is slow and income grows unevenly. And at blue, which is low, which is SSP 2.6, in the second best scenario, global carbon dioxide emissions are cut severely, but not as fast, reaching net zero after 2050. It imagines the same socioeconomic shifts towards sustainability as SSP 1.9, but temperature stabilizes around 1.8 degrees centigrade higher by the end of the century. At the light blue, which is very low, which is SSP 1.19, this is the most optimistic scenario, describing a world where global CO2 emissions are cut to net zero around 2050. Societies switch to more sustainable practices with focus shifting from economic growth to overall well-being. And investments in education and health grow. Inequality falls. Extreme weather is more common, but the world has dodged the worst impacts of climate change. So these are the choices which global leaders will have to make in the years to come. And global leaders are leaders because they are going to be elected. By whom? By the citizens of the countries. So the citizens will have to make a valid choice and give that choice to the leaders so that we have a better future. Now, another development which I would like to share with you is the database, which is going to help the migrant workers. The union government yesterday rolled out the national database for unorganized workers. This will be a single point reference to help authorities reach out to and track workers in the informal sector and offer welfare in times of crisis. The details are, next slide, please. The database comes more than a year after the nationwide lockdown imposed on 25 March 2020 to contain the spread of coronavirus triggered a mass reverse migration in the country. The chart shows the top 5 states that saw the highest reverse migration. They are Uttar Pradesh, number 1, Bihar, number 2, West Bengal, 3rd, Rajasthan, 4th, and 5th, Odisha. And India, total 11.43. Next slide, please. What is the status of this NDUW? The government is expected to roll out the database by the end of August. It comes more than a year after the mass reverse migration of workers following the nationwide lockdown imposed on 25th March 2020 to contain the spread of the coronavirus. The exercise has been delayed and the second wave of COVID-19 exposed the shortcomings. The Supreme Court criticized the Union Labour Ministry, saying it showed unpardonable sympathy towards such workers. Officially, over 11 million people went back home during the first wave. Many had to walk back, highlighting the plight of migrants. And how is the database going to help? The database will help in keeping track of migrant workers and deal better with the crisis situations such as the COVID-19 pandemic. It can help government authorities in the origin as well as destination state to plan welfare measures, including social security provisions for the workers. Such a database will also aid the One Nation, One Ration Card initiative and boost portability scheme that deal with making free food grain available, benefits through the construction workers, cess, etc. The union government is going to spend nearly 800 crore rupees on preparing this architecture. Next slide, please. The third dimension, who will be allowed to enroll with the database? Once the digital backbone is prepared by the Labour Ministry in collaboration with the National Informatics Center, the target is to enroll 380 million workers in the NDUW. All unorganized workers, including construction workers, migrants, gig and platform workers, street vendors, domestic workers, agricultural workers, and others will be added to the database. Next slide, please. Fourth dimension. When is it going to be rolled out? The project is expected to start the registration work later this month, which it has been started yesterday after addressing all critical technical issues which are being handled by the National Informatics Center. Thereafter, the state governments are to populate the data on the portal. The common service centers, through their nationwide network of over 400,000 centers and post offices, will act as the registration centers, where workers can visit and register themselves free of cost. Everyone will be given a number and their account will be linked to their 12-digit Aadhaar number. The last dimension, the fifth dimension is what could be the challenges. The project is delayed. It was supposed to start by 31st July. Besides, as migrants and informal workers are a floating population, bringing them to registration centers is a tough task. The center and states are responsible for the execution, but the initiative does not fix accountability on anyone. An informal sector database is a good move. Let's accept it is too late, but there should be a mechanism to enroll them all faster so that they get the government benefits. The labor economist, Mr. K.R. Shyamsundar said. Next, let's go to the next slide. This is summary of, again, the IPCC report, a look at the change in emission levels and rise in global temperature as projected by the Intergovernmental Panel. So the graph and projected rise in global temperature, as I told you, likely rise in global mean sea level by 2100, very low is 0.9, and medium is 1.0, very high is 1.3. The UN Secretary General Antonio Guterres said today's report is code red for humanity. It must sound a death knell for coal, fossil fuels before they destroy the planet. Projection for South Asia in 21st century, heat waves and humid heat stress to be more intense and frequent. Annual and summer monsoon precipitation to rise. Next slide, please. Another important aspect which came to light during the last 1 month was this, that researchers, they started new investigation into long COVID core outcome set. Core outcome set. A group of researchers started this project with the aim of understanding what are the core outcomes for patients living with long COVID. The World Health Organization called countries to prioritize recognition, rehabilitation, and research for the consequences of COVID-19 and the collection of standardized data on long COVID, and proposed the term post-COVID-19 condition should be used for people living with long COVID. Post-COVID-19 condition is the terminology to be used. A significant portion of people diagnosed with COVID-19 subsequently experience lasting symptoms, including fatigue, breathlessness, neurological complications months after the acute infection. However, the evidence for this condition is limited and based on small patient cohorts with short-term follow-up. There is an urgent need for development of a core outcome set. Core outcome set, a new terminology, COS, to optimize and standardize clinical data collection and reporting across studies, especially clinical trials and clinical practice for this condition. With this in mind, clinical research communities and people living with post-COVID-19 condition have come together to respond to this emerging global healthcare crisis. Next slide, please. An international group of experts in COS development and post-COVID-19 condition research and clinical practice have developed a program of research together with WHO, ISARIC, that is International Severe Acute Respiratory and Emerging Infection Consortium, and patient partners to develop the post-COVID-19 condition COS. This project, post-COVID condition core outcome, will start by surveying people living with post-COVID-19 condition and assess what outcomes matter and build a plan in 2 phases. The first phase will focus on what outcomes should be measured, and the second phase will focus on how to measure these outcomes. Researchers aim to complete the first phase, what outcomes to measure, in the summer of 21, and the second phase, how to measure these outcomes, in 2022. This project follows the COMET, that is Core Outcome Measures in Effectiveness Trials initiatives standards, and has been registered on COMET's COS registry. This plan is being globally publicized in its early stages so that research and patient communities are aware, thereby potentially avoiding any unnecessary duplication of work, and to let researchers planning studies, especially clinical trials, and clinicians know the anticipated time frame of these recommendations. So at this stage, I would like to share with you a video on COS. Shivang, could you share the video?
Hello.
The first video I sent you. What are core outcome sets? The COMET initiative video. The COMET initiative video.
Sharing, sir.
Right. This is the website of PCCOS. PC-COS. This is post-COVID core outcome set, which is a group and the WHO together seek to create a core set of outcomes that should be evaluated in all research studies and in clinical care for people with post-COVID condition, also known as long COVID or post-COVID sequelae of SARS-CoV-2 infection. The PC-COS project aims to bring together different people affected. Yeah, let's go and see the video first and come back to the slide later. Kindly bear with me for a little while before the video starts, because then we can understand the whole issue better.
Hello, I'm Laura. As a patient with asthma, I'm interested in health research. I think research is the best way to help improve treatments and develop new and better ones. That's why I'm keen to help researchers design studies that make a difference to people's lives. Researchers develop and test treatments to make sure they work and are safe. To do this, they look at the effects treatments have on patients by measuring outcomes. For example, last year I took part in Dr. Smith's study that tested a new asthma treatment. Dr. Smith measured an outcome of how often I used my reliever inhaler before and after taking the new treatment. But there is a problem, because the same outcomes aren't always measured for the same health condition, and different researchers throughout the world often measure different outcomes. So, for example, Dr. Lopez in Spain might be looking at the number of times patients have to go into hospital with their asthma as an outcome, while Dr. Bedi in India may decide to measure nighttime wheeze. When these asthma treatment studies are finished, they can't be compared or combined because they've used different outcomes. It's then difficult to know which treatment is best. It's a bit like trying to compare apples with bananas. This isn't just a challenge for asthma, but for many different health conditions affecting patients throughout the world. So, how can we solve this problem? It's simple, really. If all studies in a particular health condition measure the same set of outcomes, they can be easily compared and combined. Once agreed, this set of outcomes is called a core outcome set. But deciding on which outcomes are core requires discussions and input from the right people. The core outcomes need to be relevant to patients, like me, health professionals and researchers, so that we can design studies that are more relevant to patients. People working on core outcome sets need to make sure that patients and health professionals both have their say. To do this, they often use consensus methods. Consensus methods include surveys, meetings, and discussions where everybody's views can be heard and taken into account. When a core outcome set has been agreed, the hope is that researchers will use it in all studies for that health condition. We'll be able to learn more about the condition because findings can be compared and combined. In the long run, this means treatments that work will be available to patients more quickly. If you want to find out more information about core outcome sets, visit www.comet-initiative.org.
So friends, now you have understood what is PC-COS, the core outcome sets.
Please, don't make this mistake. Hey, this is Amit here, and
No, Shiva, that's interesting. The video didn't stop. So let's go ahead with our presentation. The PC-COS project aims to bring together different people affected by the post-COVID condition, people with lived experience and their carers, health professionals, researchers, and policymakers to establish a consensus-based list of the most important outcomes that should be consistently included in research studies and used in clinical practice. Who are the participants? And that's why this is being included in today's session. If you know people of this background, motivate them to be the participant for these studies. PCCOS project involves various stakeholder groups to ensure the perspectives of people with post-COVID condition, their family members, as well as health professionals and others involved in the care are considered. Types of PCCOS project participants are people living with long COVID, post-COVID condition. Second, family members, caregivers of people with long COVID, post-COVID condition. Third, health professional with long COVID, post-COVID condition. Fourth, researchers with long COVID, post-COVID condition. Fifth, health professionals, including those who also do research. Sixth, researchers without any clinical patient care duties. And seven, others are policymakers, etc. So there is a very wide range of people who can be participants for this project, PCCOS project. So kindly go to the website, and if you find it useful, go ahead and be a participant. PC-COS. Now, another development which occurred during the last month was that WHO's Solidarity clinical trial entered a new phase with 3 new candidate drugs. The Solidarity Plus trial for promising drugs will roll out in 52 countries, an unprecedented global collaboration for COVID-19 research and development. The WHO on 11th August announced the next phase in its Solidarity trial, that is Solidarity Plus. It will enroll hospitalized patients to test 3 new drugs in hospitalized COVID-19 patients. These therapies, artesunate, imatinib, and infliximab, were selected by an independent expert panel for their potential in reducing the risk of death in hospitalized COVID-19 patients. They are already used for other indications. Artesunate is used for severe malaria, imatinib for certain cancers, and infliximab for diseases of the immune system, such as Crohn's disease and rheumatoid arthritis. These drugs were donated for the trial by their manufacturers. Finding more effective and accessible therapeutics for COVID-19 patients remains a critical need, and WHO will lead this global effort. Dr. Tedros Adhanom Ghebreyesus, WHO Director General, said that he would like to thank the participating governments, pharmaceutical companies, hospitals, clinicians, and patients who have come together to do this in true global solidarity. The Solidarity Plus trial is a platform trial that represents the largest global collaboration among WHO member states. It involves thousands of researchers in over 600 hospitals in 52 countries, 16 more countries than the first phase of trials. India is one of the 52 countries. This allows the trial to assess the multiple treatments at the same time using a single protocol, recruiting thousands of patients to generate robust estimates on the effect of a drug may have on mortality, even moderate effects. It also allows new treatment to be added and ineffective treatment to be dropped throughout the course of the trial. Previously, 4 drugs were evaluated by the trial. The results showed that remdesivir, hydroxychloroquine, lopinavir, and interferon had little or no effect on hospitalized patients with COVID-19. Though the Solidarity Plus trial, researchers across the world have an opportunity to use their expertise and resources to contribute to global COVID-19 research. So this Solidarity Plus trial is an opportunity for everybody in the world. Next slide, please. The 3 drugs, let's see the 3 drugs in detail a little bit. Artesunate, it is produced by IPCA, is used to treat malaria. In the trial, it will be administered intravenously for 7 days using the standard dose recommended for the treatment of severe malaria. Artesunate is a derivative of artemisinin, which is an antimalarial drug extracted from the herb Artemisia annua. Artemisinin and its derivatives have been extensively used in the treatment of malaria and other parasitic diseases for over 30 years and are regarded as being very safe. The WHO COVID-19 Therapeutics Advisory Group recommended evaluating the anti-inflammatory properties of artesunate. The second drug, Imatinib, it is produced by Novartis, is used to treat certain cancers. In the trial, it will be administered orally once daily for 14 days. The dose used is the standard maintenance dose, which is at the lower end of the dose patients with hematological malignancies are given over extended periods. Imatinib is a small molecule tyrosine kinase inhibitor formulated as an oral chemotherapy drug used to treat certain types of cancer. Experimental and early clinical data suggest that imatinib reverses pulmonary capillary leak. A randomized clinical trial performed in the Netherlands reported that imatinib might confer clinical benefits in hospitalized COVID-19 patients in the absence of safety issues. The third drug, that is infliximab, produced by Johnson & Johnson, is used to treat diseases of the immune system. In the trial, it will be administered intravenously as a single dose. The dose used is a standard dose that patients with Crohn's disease are given over extended periods. Infliximab is a TNF-alpha inhibitor, a chimeric monoclonal antibody that recognizes human TNF-alpha. Anti-TNF biologics have been approved for treatment of certain autoimmune inflammatory conditions for more than 20 years, demonstrating favorable efficacy and safety in restricting broad spectrum inflammation, including in elderly populations who are most clinically vulnerable to COVID-19. So these three drugs shall be tried in 52 countries, more than 600 hospitals in the Solidarity Plus trial. Next slide, please. Let's go and come back to this new development which happened yesterday. Government to link insurance pension schemes with informal workers database. This started yesterday with eShram portal. And that is what we shall see a little bit more in detail. Next slide, please. This is the objective of eShram scheme, the portal. Integration of social security schemes, that is PMSYM, PMJJBY, PMSBY, and PMJAY. It provides a comprehensive database to central and state governments for tackling any national crisis like COVID-19 in future. Ascertaining status and address current location of migrant workers is also helped by eShram portal. Ascertaining their movement from formal to informal sector and vice versa can also be tackled through eShram. Sharing of information with other ministries and state governments for delivery of social security schemes is possible through eShram. Portability of welfare benefits to migrant and construction workers is also the objective of eShram portal. The registration on eShram portal is, registration starts yesterday. It started 26th August 2021, and Hindi and English, and in future other 8 regional languages will begin soon. Self-enrollment through portal on www.eshram.gov.in. Assisted approach through CSC and SSK over 4 lakh centers across the country and through select post offices. Requirements are simple. Registering through CSC, you need Aadhaar number and bank account details. If you are self-registering on the portal, you need Aadhaar number, bank account details, and mobile number, which is linked with the Aadhaar. So it's simple and minimal requirements. Next slide, please. Benefits of eShram are eShram card to be acceptable across the country. Accidental insurance coverage through PMSBY for a year. Rupees 2 lakh for accidental death and permanent disability, and rupees 1 lakh for partial disability. Social security benefits to be delivered through this portal. It is helpful for state and central governments while providing assistance during calamities and pandemics. Next slide, please. What is the role of the state governments? The role is that there are 5 roles. One is mobilizing workers for registration. Second, populating data on eShram portal. Third, using data on delivery of social security scheme. Fourth, state level monitoring committee. And fifth, district level implementation committee. Next slide, please. This is the constitution of state level monitoring committee, with chairperson as the chief secretary is the chairperson. Additional chief secretary and principal secretary of labor department is a member. Other principal secretaries are members. Members also are there, which are President, Secretary of state level unions, associations and federations of unorganized workers, BOCW workers, SHG under NULM and NRLM members, domestic workers, ASHA workers, Anganwadi workers, street vendors, rickshaw pullers, brick kiln workers, agricultural laborers, MG Narega workers, fishermen associations, and state level unions, associations of shopkeepers and small retailers. And the objective of the state level monitoring committee is overall supervision and monitoring of progress in state and taking appropriate action for achieving the target. In addition, there is a district level implementation committee. The chairperson shall be the district magistrate or district commissioner or collector, deputy commissioner or collector. Member secretary shall be assistant labor commissioner or district labor officer. And district level officers of line departments shall be members. In addition, the president, secretary of district level unions and associations of unorganized workers, building and other construction workers, self-help groups under NULM and NRLM members, domestic workers, ASHA workers, Anganwadi workers, street vendors, rickshaw pullers, brick kiln workers, agricultural laborers, MG Narega workers, fishermen, and any other such workers association shall also be members. Function of the district level implementation committee is to implement the registration process within the district and achieving the target set by the state level monitoring committee. So with eShram, now we go to another dimension. This is a research work published in the journal Occupational Medicine, where the study of workers with major depressive disorder found that males more frequently reported reduced work efficiency compared with females. Managers should pay attention to the level of functioning in employees and provide appropriate social support. This study was done in Japan, and this has been published in a journal Occupational Medicine. The conclusion suggests that there is greater attention to reduce work efficiency by men and to deterioration in work relationships by women with MDD. This should be an essential component of self-care, and managers need to pay attention to the level of functioning and provide adequate social support for employees. The results were as a result of the survey to 147 workers with MDD. MDD is major depressive disorder. In terms of gender, differences in initial self-perceived changes in the level of functioning at work, the proportion of men reporting reduced work efficiency was significantly higher than that of women, while the proportion of women reporting deterioration in relationships with colleagues and superiors was significantly higher than that of men. That is a different observation and the results of this study. Next slide, please. There is an editorial in the journal Occupational Medicine about collaboration with public health and practice of occupational health in the times of COVID-19 and beyond. This editorial describes how collaboration with public health has enabled an occupational health team to remain up to date during unprecedented demand, facilitated by preparation of evidence summaries in real time by the public health team. Next slide, please. This is the article, an alliance with public health in pursuit of COVID-19 evidence. The COVID-19 pandemic presented occupational health teams with unprecedented challenges and demands. Early in the pandemic, guidance from specialty societies and Royal colleges began to emerge. It was often based on extrapolation from pathogens before SARS-CoV-2, not specific enough to inform the frequently complex scenario facing occupational health specialists, and at times contradictory. Hefty responsibility fell on the shoulders of occupational health professionals, who hold the delicate balance of advising on how best to protect staff while not compromising care for patients. Public health is like occupational health, a relatively small specialty. Its focus is on population and communities rather than individuals, and its mission is to work collaboratively with all relevant stakeholders to improve health and reduce health inequalities. As is the case in occupational health, the discipline has been profoundly affected by the pandemic. Most of the workforce was redeployed or diverted to the COVID-19 response. BSEX in the south of England was no exception, with consultants and specialty trainees seeking ways to apply their skills to protect the health of the public. One of the core skills and objectives of public health professionals is to use evidence and intelligence to inform practice, assess risk, and influence policymakers. In a new collaboration, public health colleagues offered to provide rapid, regular evidence support in order to inform the decision-making of occupational health colleagues in a tertiary National Health Service Foundation Trust responsible for over 11,000 staff. So this editorial drives the argument that Alliance of Public Health in pursuit of COVID-19 evidence with occupational professionals is essential. And if you look at the last paragraph, the pandemic has shown a light not only on blind spots and inefficiencies in the way healthcare systems operate, but also an opportunity that exists for collaboration and support between specialties and teams. Our alliance has enabled the OST to remain up to date during the unprecedented demand, facilitated by preparation of evidence summaries in real time by the public health team. The project cannot and will not continue indefinitely. As the evidence base on COVID-19 strengthens, the need for constant review of the literature lessens. However, this project has fostered new effective ways of interdisciplinary working, and we are actively considering ways in which the learning from this work can be furthered in an ongoing collaboration. Our experience is also a reminder that not all NHS trusts employ or have direct access to public health specialists. This collaboration is just one practical example of many ways public health professionals can make a valuable contribution in the hospital setting, working synergistically with other specialties, not only at times of crisis, but routinely helping trusts to both treat and prevent. So the argument is collaborate, collaborate, collaborate. Next slide. Another important article which got published during the last month was SARS-CoV-2 IgG response in symptomatic and asymptomatic COVID-19 infected healthcare workers. And it is published by authors from Argentina. Next slide, please. The background and aims and methods are shown in the slide. I would like to share the results. Results are the SARS-CoV-2 IgG seropositivity rate was 77%. This seropositivity rate was higher in symptomatic than in asymptomatic COVID-19 infection, 83% versus 57%. And in older healthcare workers, the seropositivity rate did not diminish with time. In logistic regression, only a history of COVID-19 symptoms and age were identified as independent factors associated with the detection of anti-SARS-CoV-2 IgG antibodies. The conclusion is that SARS-CoV-2 IgG antibodies are found significantly more frequently in symptomatic and in older healthcare workers. The fact that not all COVID-19 healthcare workers develop detectable IgG is vital for the interpretation of COVID-19 seroprevalence surveys. So that is important. This is a clear evidence that there can be substantial number of individuals without any detectable IgG levels. Next slide, please. The key learning points are that this study adds that not all healthcare workers have positive serology after COVID-19 infection. Detectable SARS-CoV-2 IgG antibodies are more frequently observed in symptomatic and in older healthcare workers. The seropositivity rate in samples obtained after 8 weeks did not differ significantly from those with a shorter time interval. And what impact this may have on practice or policy, the fact that not all COVID-19 healthcare workers have a positive serology is vital for the interpretation of seroprevalence surveys. The detection of SARS-CoV-2 antibodies in healthcare workers could be useful in settings where there is a limited vaccine availability. So these are two important impact that on practice and policy. Let's go and see something else. This is a visual which reinforces the point that you need to measure your blood pressure periodically to be able to understand the risk that you are carrying. Let's see the global trends. Next slide, please. More than 700 million people with untreated hypertension. Number of people living with hypertension has doubled to 1.28 billion since 1990. World Health Organization and Imperial College London, they jointly brought out this report. The number of adults aged 30 to 79 years with hypertension has increased from 650 million to 1.28 billion in the last 30 years, according to the first comprehensive global analysis of trends in hypertension prevalence, detection, treatment, and control, led by Imperial College London and WHO, and published on Lancet yesterday. Nearly half these people did not know they had hypertension. Hypertension significantly increases the risk of heart, brain, and kidney diseases, and is one of the top causes of death and disease throughout the world. It can be easily detected through measuring blood pressure at home or in a health center, and can often be treated effectively with medications that are low cost. The study, conducted by a global network of physicians and researchers, covered the period 1990 to 2019, a period which is 30 years. It used blood pressure measurement and treatment data from over 100 million people aged 30 to 79 years in 184 countries, together covering 99% of the global population, which makes it the most comprehensive review of global trends in hypertension to date. By analyzing this massive amount of data, the researchers found that there was little change in the overall rate of hypertension in the world from 1990 to 2019. But the burden has shifted from wealthy nations to low and middle income countries. And that is why it is important for India to rise and to wake up. The rate of hypertension has decreased in wealthy countries, which now typically have some of the lowest rates, but has increased in many low or middle income countries. As a result, Canada, Peru, and Switzerland had among the lowest prevalence of hypertension in the world in 2019, while some of the highest rates were seen in the Dominican Republic, Jamaica, and Paraguay for women, and Hungary, Paraguay, and Poland for men. Although the percent of people who have hypertension has changed little since 1990, the number of people with hypertension doubled to 1.28 billion. This was primarily due to population growth and aging. In 2019, over 1 billion people with hypertension, that is 82% of all people with hypertension in the world, lived in low or middle income countries. Imagine 82% of the people with hypertension are living in the low and middle income countries. So it is hitting India, definitely. Next slide, please. There are significant gaps in diagnosis and treatment. Although it is straightforward to diagnose hypertension and relatively easy to treat the condition with low-cost drugs, the study revealed significant gaps in diagnosis and treatment. About 580 million people with hypertension, that is 41% of women and 51% of men, were unaware of their condition because they were never diagnosed. The study also indicated that more than half of people, that is 53% of women and 62% of men with hypertension, or a total 720 million people, were not receiving the treatment that they need. Blood pressure was controlled, which means medicines were effective in bringing blood pressure to normal range in fewer than 1 in 4 women and 1 in 5 men with hypertension. Imagine the gap between the need and the need being met. Professor Majid Ezati, who is a senior author of the study and professor of global environmental health at the School of Public Health at Imperial College London, said, nearly half a century after we started treating hypertension, which is easy to diagnose and treat with low-cost medicines, it is a public health failure that so many of the people with high blood pressure in the world are still not getting the treatment they need. Men and women in Canada, Iceland, and Republic of Korea were most likely to receive medication to effectively treat and control their hypertension, with more than 70% of those with hypertension receiving treatment in 2019. Comparatively, men and women in sub-Saharan Africa, Central Asia, South Asia, and Southeast Asia. Remember, South Asia as well, where India is situated. Pacific Island nations are the least likely to receive the medication. Treatment rates were below 25% for women and 20% for men in a number of countries in these regions, creating a massive global inequity in treatment. Encouragingly, some middle-income countries have successfully scaled up treatment and are now achieving better treatment and control rates than most high-income nations. For example, Costa Rica and Kazakhstan now have higher treatment rates than most higher-income countries. Dr. Bin Zhao, a research fellow at the School of Public Health at Imperial College London, who led the analysis, said, although hypertension treatment and control rates have improved in most countries since 1990, there has been little change in much of the sub-Saharan Africa and Pacific Island nations. International funders and national governments need to prioritize global treatment equity for this major global health risk. It's a major global health risk. The new WHO guideline for hypertension treatment have also been released on 25th of August 2021. They provide new recommendations to help countries improve the management of hypertension. Dr. Taskeen Khan of WHO Department of Non-Communicable Diseases, who led the guideline development, said the new global guideline on the treatment of hypertension, the first in 20 years, provide the most current and relevant evidence-based guidance on the initiation of medicines for hypertension in adults. The recommendations cover the level of blood pressure to start medication, what type of machine or combination of medicines to use, the target blood pressure level, and how often to have follow-up checks on blood pressure. In addition, the guideline provides the basis for how physicians and other healthcare workers can contribute to improving hypertension detection and management. Dr. Bente Mikkelsen, Director of WHO Department of Non-Communicable Diseases, added the need to better manage hypertension cannot be exaggerated. By following the recommendation, this new guideline, increasing and improving access to blood pressure medication, identifying and treating comorbidities such as diabetes and pre-existing heart disease, promoting healthier diets and regular physical activity, and more strictly controlling tobacco products, countries will be able to save lives and reduce public health expenditures. Next slide, please. Here we see the top 10 countries with the lowest hypertension prevalence in 2019. For women, it is Switzerland, Peru, Canada, Taiwan, Spain, Korea, Japan, UK, China, and Iceland. For men, it is Eritrea, Peru, Bangladesh, Canada, Ethiopia, Solomon Islands, Papua New Guinea, Laos, PDR, Cambodia, and Switzerland. These are the top 10 countries with the highest hypertension prevalence in 2019. And which are these? For women, it is Paraguay, Tuvalu, Dominica, Dominican Republic, Sao Tome and Principe, Jamaica, Haiti, Iraq, Eswatini, Botswana. And for men, it is Paraguay, Hungary, Poland, Argentina, Lithuania, Romania, Belarus, Croatia, Tajikistan, and Serbia. Next slide, please. These are the top 10 countries with highest hypertension treatment rate in 2019. For women, it is Korea Republic, Costa Rica, Kazakhstan, United States of America, Iceland, Venezuela, El Salvador, Portugal, Canada, and Slovakia. For men, it is Canada, Iceland, Korea, USA, Kazakhstan, Malta, Costa Rica, Germany, Czechia, and Singapore. Next slide, please. These are the top 10 countries with the lowest hypertension treatment rate in 2019. Let's see which are these countries. For women, Rwanda, Niger, Kiribati, Ethiopia, Vanuatu, Tanzania, Solomon Island, Madagascar, Mozambique, Kenya, all are in Africa, sub-Saharan Africa. For men, it is Rwanda, Kenya, Mozambique, Vanuatu, Solomon Island, Niger, Madagascar, Uganda, Togo, and Burkina Faso. Imagine the rates. Look at the rates and percentage. These are the top 10 countries with the largest increase in hypertension prevalence between 1990 and 2019. For women, it is Kiribati, 13% increase, Tonga, Tuvalu, Indonesia, Brunei, Dar es Salaam, Haiti, Jamaica, Myanmar, Samoa, Uzbekistan. For men, they are Uzbekistan, Argentina, Paraguay, South Africa, China, Brunei, Dar es Salaam, Tajikistan, Jamaica, Dominican Republic, and Tuvalu. Next slide, please. These are the top 10 countries with the largest decline in hypertension prevalence between 1990 and 2019. For women, it is Germany, Spain, Japan, Singapore, Russian Federation, Italy, Australia, UK, Israel, and Sweden, all the highly developed countries. For men, it is Germany, Switzerland, UK, Finland, Canada, Luxembourg, Norway, Austria, Italy, and Malawi. All except Malawi are highly developed countries. Next slide, please. These are the top 10 countries with the largest increase in treatment rate between 1990 and 2019. Republic of Korea, Taiwan, South Africa, Costa Rica, Poland, Venezuela, Serbia, Brunei, Singapore, and Colombia. For men, Korea, Canada, Costa Rica, Germany, Iceland, Taiwan, Kazakhstan, Poland, Switzerland, and Norway. Next slide, please. Now, we go to the 3 events which are going to happen in the next foreseeable future. The first event is happening from 3rd to 6th of September 2021. That is the World Congress of Epidemiology, fully digital. It is held every 3 years. The World Congress of Epidemiology will come to you virtually, and the International Epidemiological Association and the Australasian Epidemiology Association will be organizing this. It's a premier conference on epidemiology that will focus on methodological innovations in epidemiology, which reflect the innovative progress in epidemiology and public health. The 4 days include workshops, symposiums, special keynote sessions conducted by eminent, renowned speakers who excel in the field of epidemiology. Will include methodological addressing public health problems and data science, linked data, precision prevention, screening, call thinking, new advances, study designs, innovation in data collection, wearable technologies, new technology, methodology for participant recruitment and retention, evidence-based medicine, clinical practice, evidence-informed health policy, epidemics and other global health emergencies, social epidemiology and inequities, genetic and molecular epidemiology, climate change, patient and public involvement in epidemiological studies. A very wide range of topics. Second event will be happening in September from 20 to 23rd of September 2021. The 22nd World Congress of Safety and Health at Work. It will again be fully digital conference. The theme is prevention. It's on everybody's mind. Prevention in the connected age, global solutions to achieve the safe and healthy work for all. Next slide, please. And the third event, the 33rd International Congress on Occupational Health, being organized by International Commission on Occupational Health from 6 to 10 February 2022. 2 stages for a great digital experience. Melbourne, Rome, Global Digital Congress. So Melbourne and Rome together will be organizing this Global Digital Congress from 6 to 10 February 2022. Next slide, please. The theme of the conference is sharing solutions in occupational health through and beyond the pandemic. 6 to 10 February, Melbourne, Rome, Global Digital Congress. Next slide, please. The dates, important dates are registration open and early bird offer 15 June 2021 starting. Call for abstract open 15 June 2021. Abstract submission close is on 31st August. Please remember, abstract shall be closing on 31st August. Notification of abstract acceptance will be by 31st October. Deadline for accepted presenter to confirm participation is 9th of November. And standard registration fees on offer shall be from 10th of November. Next slide, please. This is the list of opening keynote speaker and plenary keynote speakers. Sir Michael Marmot of University College, UK, shall be speaking on health inequalities in the workplace. And plenary keynote speaker, you have Dr. Soumya Swaminathan from WHO, the impact of COVID-19 in developing countries will be also there. And Paul Blanc from University of California, San Francisco, Lee Fritchie from Curtin University, Australia, Karen from Cornell Institute, Amsterdam, Jeremy Rantanen from Finnish Institute of Occupational Health. You have Anita Dani from Indonesia, Margaret Kitt from USA, Do Yong Park from Korea, and you have University of Sao Paulo, Brazil, Frida Martina Fischer, Franklin Moshiri from Switzerland, Frank Pega from WHO, and Alistair Woodward from New Zealand. So we have a wide range of speakers, very reputed speakers with very wide range of topics as keynote speakers. Next slide, please. And look at the wide range of topics that you can submit your abstracts on. Both oral and poster sessions will be interactive, providing chat rooms to stimulate the discussion among participants and presenters. So get ready to submit your abstracts in any of the scientific streams, the tracks that you are seeing on the screen in this slide, right from A to W. Accident prevention, aging and work, allergy and immunotoxicology, cardiology in occupational health, education and training in occupational health, effectiveness in occupational health services, emergency preparedness and response in occupational health, epidemiology in occupational health, history of prevention of occupational and environmental diseases, indoor air quality in health, industrial hygiene, mining occupational safety in health, musculoskeletal disorders, nanomaterial workers health, neurotoxicology and psychophysiology, occupational environmental dermatosis, occupational health and COVID-19, occupational health nursing, occupational medicine, occupational toxicology, occupational health and development, occupational health for health workers, occupational health in the chemical industry, occupational health in the construction industry, radiation and work, reproductive hazards in the workplace, respiratory disorders, rural health, agriculture, pesticides and organic dust, shift work and working time, small scale enterprises and the informal sector, thermal factor, toxicology of metals, unemployment, job insecurity in health, vibration and noise, women, health and work, work and vision, work disability prevention and integration, work organization and psychosocial factors. Another highlight is accepted abstracts for oral and poster sessions will be published in an online supplement of safety and health at work, that is SHAW, one of the key international journals in its field and part of the Elsevier group. Impact factor is 2.707, very, very high. Online abstract submission has already opened on 15th of June. Information on how to make your submission is detailed on the website, along with a complete list of themes and sub-themes. And the closing date is 31st of August. 31st of August. So get ready, get your submission. So with this, I again remind you, come again back to this webinar on Friday, September 24, the last Friday of next month at 6:30 p.m. for another episode of OcuHealthscapes. Thank you so much for your patient listening.
Thank you, sir. Thank you very much for this elaborative session, knowledge sharing session. Of course, a lot of topics were covered on environment, unorganized sector, migrant workers, post-COVID, and also a very interesting share of on major depressive disorders, comparison between men and women. That was a very interesting paper. And also the importance of public health experts, not only in pandemic, but also in non-pandemic times. That was a very good session by you. And also you mentioned about the study on IgG, which can impact the seroprevalence data. That is a very important factor to be considered when we have those kind of data. And also your talk on hypertension was very, very good. And also you shared the major global health risk, and also WHO guidelines for hypertension. And also you gave an update on World Congress of Epidemiology, World Congress on Safety and Health, and also the ICO conference. So thank you for that. And we open for questions and also comments from the panelists. So we will open for all comments and also the questions if anybody has to say anything. Dr. Ashish Jain, anything from you?
I think this is becoming really something like a habit. It's wonderful to hear Dr. Rajiv, not only in the monthly Healthscapes, but also our regular talks, which happen on Saturday. As usual, it's an academic feast for all of us. And I'm always keen to hear about many new things and learn about it. So thank you, Dr. Rajiv, for that. And I should also say that excellent facilitation. So you are doing a brilliant job.
Thank you so much.
Thank you, Dr. Ashish. We'll go to the next, Dr. Sanjay. The comments, questions from you.
Yeah, good evening, sir. Brilliant work. Brilliant work. Keep updating us.
Thank you. Always welcome.
Yeah.
Thank you, Dr. Sanjay. Dr. Thagaraju. Dr. Thagaraju, can unmute yourself.
Thank you, Dr. Guru Prasad. We are seeing you once again here. Can you hear me, Guru Prasad? Hello?
Yeah. We can hear you, sir. We can hear you.
Thank you, Dr. Guru Prasad. Once again, we are seeing you here as a moderator. Very nice moderated you have done with a short time. And our Rajesh Jain, as you say, that is a wonderful speaker. Very nice presentation. Especially I too was very happy when he presented about the hypertension, especially for women and the men. And he has elaborated more about the HICO. Thank you, sir. Thank you very much. Best of luck for India for the next 27th conference. Thank you.
Thank you, sir. Dr. Pawan Gupta.
you so much, Dr. Guru Prasad, for the opportunity. My pleasures. Very good evening to Dr. Jan and to all the panelists. Such a pleasure to hear him always. There's so much of knowledge bank. And today as well, it was the same. We keep learning a lot. I really appreciate his gesture of sparing time, bringing all the information from across the globe and sharing it with us. Thank you so much, Dr. Jan. I can only say that there were a lot of points, definitely, which we have received a lot of information. If I'll have some queries, I'll reach out to you for sure.
Thanks, Dr. Pawan. Thank you very much. Dr. Shyam, sir. Shyam Pingla, sir. Okay, we can come back to Shyam, sir, later. Dr. Shashikala?
Hear me?
Shashikala, madam? Yes, sir. Shyam, sir, you can go ahead.
Yeah.
Sir.
Yeah. Thank you, Dr. Rajiv Jain, for an excellent presentation. You have done a lot of work for our benefit, and that keeps us updated, all of us. Thank you so much. I'm especially happy about the information which is once again shared by Dr. Jain about ICO Congress. I would request all of us should register for the Congress. There cannot be a cheaper opportunity for us to attend the ICO Congress from our home and our office and at such a low cost. And 31st August is the last date for abstract submission. All of us should try to present their abstract, some views and something, and make the conference really interesting and interactive and leave an impression of India on the conference. Thank you.
And to supplement Dr. Shyam, I would like to further inform the audience that if you submit an abstract, you stand a chance to get waiver of full registration fees. There is a huge number of waiver of registration fees available. Those grants will be declared after acceptance of your abstracts. So there is a good number of bursaries available, waiver of registration fees available for people from India, because India, as per World Bank classification, continues to be in the low and middle income countries. For low and very low income countries, there is a huge subsidy would be available.
Thank you,
so even
Shyam, sir.
the low cost will be zero cost. There is a possibility. Yeah.
That's a great news, sir. So anybody, so 31st is the last date. Please submit your abstracts. That's a very good piece of information, sir. Thank you, Rajiv, sir. I think we have completed the panelists. We'll go to attendees.
Just one second.
Yeah, madam, sir.
Good evening.
Yeah, sorry.
Good
yeah,
evening,
please
everybody.
go ahead.
Thank you, Dr. Jain, for a nice presentation. I just have one question. How is ozone layer affecting the air pollution?
Well, ozone layer is a major cause, in fact, for global warming. And if we consider all aspects, if you see climate change, one of the targets which are already there till from 2000 to 2030, one of the major was controlling the ozone layer emissions, and all the greenhouse gases and ozone layer are interlinked, and this effort need to further be strengthened in the days and years to come. Ozone will contribute a substantial, I'd say, portion of global warming.
Thank you. Thank you.
You are muted, Dr. Guru Prasad.
Yeah, sorry, sir. Okay, we'll go to attendees. Anybody from attendees? Dr. Damodar Lele, you have any questions, comments?
I have a question.
Yes.
First is, I have not understood anything about that video, what was shown and what was the purpose. I'm sorry because I'm dumb, but
No, I can understand. I can understand. The PCCOS, the set of outcomes, they determine the research project. Now, for long COVID, each country, the research goes on, there will be different outcomes. But if all collaborate with a specific set of outcomes, then it is possible to have tangible results for a large population, for the entire world, for the long COVID. This PCCOS project is being coordinated by WHO, and the website PC-COS is live now. Kindly go to the website. The COS aspect is only to highlight that this is an important way to do large research, the global level of research for new methodology of treatment. So that was the purpose. The video was showing you about PC, the COS portion.
The second question was about chief secretary being member of every committee or chairman. How do they manage? Because they are present everywhere.
Well, very right. But this is only to give effective teeth to the committees. Like in the district level committee, you must have seen the district magistrate being the chair, and in the state, the chief secretary being the chair. It ensures that there is decision making and effective monitoring which happens. The implementation also becomes more effective if the chair is headed by the head of administration, that district. This is only to ensure effectiveness and proper implementation of the scheme. The e-shram is, if you had seen my background, the Supreme Court had given direction to Government of India to have this going. And this is now, yesterday was inaugurated with the hope that that gap which we found in the initial period of COVID-19 lockdown in March last year will not occur in future ever. There's a most pathetic sight to see in Delhi, Mumbai, Bangalore, and city after city, Ahmedabad, people walking on the road and have no means to subsist their lives, the lives and livelihood issue. So it is only to prevent the disasters which are preventable disasters in future.
Thank you. Thank you very much, sir.
Thank you, sir. Thank you, Dr. Damodar. We'll go to Dr. Chandrasekhar Valapalli. Dr. Hitesh Shah, any comments or questions from your end? Dr. Hitesh or Dr. Chandrasekhar, anybody? I think we are done, sir. So all the questions, comments done. Anybody wants to comment again? Okay. Thank you, sir. Thank you, Dr. Jain.
I have a video for the closing of this episode of OcuHealthscapes, which is a choir. Choir is to create memories together, and OcuHealthscapes is designed to create memories together. So kindly enjoy this video of creating COVID-19. It's a children's choir, and I hope all the attendees and people who visit the video website or the webinar platform on YouTube shall also enjoy this video. So I would like your permission to play this video. Dr. Guru Prasad.
Sure, sir. Sure, sir.
So Shivang, play that video.
We'll have the video, please.
Memories. Children's choir. Just hold on for a while, and all of you will enjoy this video, which is children's choir. Yes, that's it.
Here's to the ones that we got. Cheers to the wish you were here, but you're not, 'cause the dreams bring back all the memories of everything we've been through. Close to the ones here today, close to the ones that we lost on the way, 'cause the dreams bring back all the memories, and the memories bring back you. There's a time that I remember When I did not know no pain, when I believed in forever and everything would stay the same. Now my heart feel like December, when somebody say your name. Cause I can't reach out to call you, but I know I will one day, yeah.
Everybody hurts sometimes, everybody hurts someday, yeah. But everything will be alright. Go raise your voice and say, hey.
Here's to the ones that we got. Cheers to the wish you were here, but you're not. Cause the dreams bring back all the memories of everything we've been through. Close to the ones here today. Close to the ones that we lost on the way. Cause the dreams bring back all the memories. And the memories bring back you. Memories bring back you. There's a time that I remember when I never felt so lost. When I felt that all the hatred was too powerful to stop. Now my heart feels like an ember, and it's lighting up the dark. I'll carry these torches for you, but you know I'll never drop. Yeah.
Everybody hurts sometimes, everybody hurts someday, hey, hey.
But everything gon' be alright. Go and raise your voice and say, hey. Here's to the ones that we got. Cheers to the wish you were here, but you're not. Cause the dreams bring back all those memories of everything we've been through. Close to the ones here today. Close to the ones that we lost on the way. Cause the dreams bring back all the memories. And the memories bring back you. Do, 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 do. Memories bring back you. Do, 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 memories bring back you. Do, memories bring back you. Here's to the memories bring back you. Memories bring back you.
Wonderful video, sir. Memories bring back you. And always a dramatic, opening and also end with, for your talk always. Thanks, sir. Thanks very much. Any closing talks by you, sir?
Nothing but keep coming back every last Friday at 6:30 p.m. to share an update on occupational and environmental health. That is the only thing I would like to share.
Thank you, sir. And also be
so much
ready
for
for all the surprised knowledge you give, the wealth of knowledge you give every weekend. Thank you, sir. Thank you very much. Thank you very much.
Thank you.
Thank you all the panelists and
Thank you very
attendees for
much.
attending session.
Thank
Thank
you,
you very
everyone.
much. Thank you.